Okay, why don't we go ahead and get started? I don't want to steal Dr. Deen's thunder, but we are making sure that we start on time. Thank you, everyone, for joining us. I'm Hector Flores. I'm a board member of the LA County Medical Association. This is really Dr. Deen's vision to develop an educational program around some of the things that we're expecting to see in the coming weeks as the Governor's Healthcare, the Healthy California for All Commission report comes out, as well as the buzz that we hear about reform in California with Governor Newsom leading the charge in advance of that commission. It's a real pleasure for us to introduce this educational program. We're going to have a series. You'll be updated with other speakers. Thanks to Dustin Corcoran, who graciously offered to really kick off this campaign for us. Most of you know Dustin, but I do want to make sure that for those of you who don't know him, are able to get a little bit of a sense of who he is and his background. Dustin is the Chief Executive Officer of the California Medical Association, which is a nonprofit organization of nearly 50,000 physicians in California. And as CEO, he has the overall responsibility for strategy as well as supervision of our projects. There's a long list of accomplishments that Dustin has made on behalf of our doctors and our patients in California since he joined CMA, but also as a CEO. Most importantly, I think the big fight right now is the micro fight to protect micro. And secondly, he led the charge to make sure that we had Prop 56 to support doctors who serve Medi-Cal patients, but also support the pipeline of future physicians in California. So without further ado, I want to thank Dustin for agreeing to be our first speaker. His topic today is expanding coverage in California. And I wish we could do this in live and give you a standing ovation, Dustin, for all the work you've done. But welcome and thank you for joining us tonight.
Thank you, Dr. Flores. Pleasure to be here. And since I'm the inaugural speaker, you're going to have to walk me through a bit about how you want this format to go. I know the topic that we're here to talk about, and I'm happy to jump in and start covering some of those items, or do you want to make this a bit more conversational and have some back and forth?
If you can do it, thank you for asking. If you can do it as a presentation, that kind of sets a frame of discussion, and then we'll have Q&A.
Sure, happy to do that, and do want to make at least the end part of this conversation where people can ask questions about what's going on up here in Sacramento, and I'll try and touch on a bit in Washington, D.C. as well. I'm sure as many of you know, California has been a leader in expanding coverage to our residents here in the state. Compared to other states, we're just far beyond that. We took full advantage of the Affordable Care Act and did major expansions under the ACA and continue to do that, including expanding even beyond what the ACA allowed for with expansion of Medi-Cal coverage, state-only funded Medi-Cal coverage for undocumented individuals here in the state. So California has done an excellent job to date on that compared to our peers in other places. As we look out over the horizon, I believe the governor's certainly committed to continuing that expansion, and we saw that in his first couple of years with the expansion to undocumented individuals, something that prior administrations have resisted here in the state, and I believe his commitment to that will continue and will endure, and I think it will be reflected rather prominently in the state budget that will come out, his budget proposal in January. We do have some interesting debates, though, here in the state, and a lot of what you'll hear about is the debate between whether we should pursue a single payer model or whether we should continue to pursue expansion of what we have done based on the Affordable Care Act, which is a multi-payer system, not a single payer system. There was a lot of conversation in his initial campaign for governor. He made quite a few statements about wanting to pursue a single payer system here in the state of California. And in continuation of that conversation has set up a commission that is looking at the feasibility of a single payer system here in the state of California. That commission is due to have its report out as early potentially as late January about what their recommendations might be. At the moment, it seems to have a lot of conversations around a unified financing model. and whether that is something that California should pursue or not. That commission, of course, would have to go in front of the legislature, and the legislature would have to pass whatever recommendations came out of there, if they're substantive in nature at all. From our vantage point here at CMA, we actually have a committee of physicians that's been meeting alongside the commission's meetings and reviewing the work that they're doing and coming up with their own recommendations. The CMA Board of Trustees will be taking that up in January, and encourage many of you that are physicians on this. If you want to get active and engaged in that, please do, because there's an open comment period before the board votes where people can get engaged about how they think CMA should be positioned on it. Nearly every year at our House delegates, there's debate about whether we're going to be in favor of continuing the multi-payer financing system or backing a single payer system. CMA has historically and still has favored a multi-payer finance system that builds on what we've done under the Affordable Care Act as enacted by President Obama. The jump to a single payer system for the state, I think, is a rather significant one, and might be a rather difficult and painful one for the state to undertake. And one of the things to look for in the coming debate in Sacramento is how much can the state really do on its own to move to a unified financing model or to a single payer system. Remember that a significant portion of the expansion under the Affordable Care Act was financed by the federal government through expansions in Medicaid. In California, half of that is paid for by the federal government, and we have to comply and follow a significant number of federal rules in the Medicaid system. We can't just do whatever we want to do in Medi-Cal unless we're willing to finance the entirety of on our own, as we did with the undocumented population. But to be clear, the budget of the state of California, in my view, is not big enough to be able to finance the entirety of that expansion without the federal dollars that come in on the Medicaid side. And you also have to add in the dollars that come in both on the Medicare side and then on subsidies that the federal government has put in for significant portions of the covered California population as well. So we have three different places where you have federal governmental dollars flowing into the state of California. The feds would have to make some significant concessions for California to be able to operate a state-only unified financing model or a single payer system. The state, in my view, again, doesn't have the capacity or the ability to be able to do that on its own. So in the meantime, from CMA's perspective, we'll continue to support expansion of coverage to every single Californian in the state. Again, we've applauded the governor's moves in that direction. We were very excited when we got a healthcare governor in, and this governor is significantly more committed to healthcare than his predecessor, Jerry Brown, was, who viewed it more as an expense to be mitigated and reined in rather than an investment in our citizens here in the state. And Governor Newsom, I think, has more appropriately taken that view of healthcare coverage for all Californians. I do want to touch on, in addition to coverage, I want to touch on access as well, because I think people too often blend the two things and interpret coverage as being the same as access. And what we still have here in the state of California, even with a significant expansion of coverage takes a lot of different forms. Medicaid coverage, Medi-Cal here in the state, access in that program still lags far behind commercial coverage for too many Californians. Covered California has done a far better job, in my view, as a blended approach of building out their networks more significantly than the Medicaid program has in the state. So when we talk about coverage, we can't lose sight of access as well. Just having an insurance card doesn't mean you have access to a physician or to a healthcare practitioner of your choosing when and where you need it. And I see it too often in my role here, people that just get stymied, get frustrated trying to find their way to the proper physician and the proper care that they need in that moment. That was really exacerbated during the COVID pandemic. What we saw, the disparities between the haves and the have-nots just got a whole lot worse. Patients in our Central Valley, in our urban communities, in our rural communities, really struggled with access to some basic services and care. Even though they were insured, even though COVID costs were supposed to be covered, testing sites were limited, vaccination sites remain limited in those communities. In fact, and this is a telling statistic, the tightest correlation on vaccination rates, far greater than anything else, is the number of vaccination clinics in a community. There's almost direct correlation between vaccination rates and that. So if you're not able to even get a COVID vaccine or not be able to easily get one, how are you going to access more complex services? We always had to have these debates in the state. You know, somebody that's working 2 jobs, doesn't have access to a car, they're not going to be able to take a day off of work, 3 buses to get to Dodger Stadium to get their COVID vaccination. They need to be able to go to their community provider, community clinic, FQHC, to be able to get that. And that's where I think an opportunity for the state really exists here, to not lose sight of coverage and not stay focused and pay attention to access. Whatever the modality is the state wants to pursue, and I know there are people that are passionate about single payer as the proper financing mechanism. There are people that are passionate about it being a multi-payer system, but the output of that, either one, should be very simply focused on providing excellent access to care, high quality care to people that need it, irrespective of where they live, who they are, or the community that they reside in. And again, the pandemic laid that bare. I'm going to share a couple stats that is very particular to physician practices, but this impacts directly care provided in those communities. We've now done 3 financial surveys of physician financial well-being over the course of COVID. And consistently, what we've seen is a significant decrease in patient volume, decrease in physician revenue, and a corollary decrease in staffing in those physician offices. Physicians are cutting back on staff, which means they're cutting back on hours, means you can't see as many patients, and you get stuck in a never-ending cycle there. Again, the communities that have been hardest hit are those that have higher Medi-Cal populations than commercial. Everybody's hurting, but there's a disproportionate effect on those providers that are in the hardest hit communities, both hardest hit from a COVID perspective, but hardest hit from an economic perspective as well. And I don't think there's going to be a silver bullet in the course of this debate to be able to fix that. There was one of the questions that I was asked to address is what are in the different strategies in thinking that a multi-payer system versus a single payer system, how much is in the state's control, how much is not. I think that gets oversimplified as well, that the state can just wish it and we can make it happen if there's a vote of the legislature. But as I mentioned earlier, there's a lot more that needs to happen. There's a lot of federal rules that are going to have to change. And those federal rules would have to change in a significant way. And I wouldn't be comfortable personally with just saying, well, we're going to get a waiver from Health and Human Services, and now we're going to move into a single payer structured system or unified financing model where Medicaid dollars and Medicare dollars flowed into the state. Because if that's all it is, and it was a decision of President Biden, what happens when there's another president that comes in? If it's not enacted and enshrined into law by Congress, it's too easy for an administration potentially to be able to change the rules when that administration changes. And we should not be waxing and waning in our ability to be able to cover Californians based on whatever administration might be elected in Washington, D.C. At a given moment. So we have to be very thoughtful about how much we do and how aggressive we are as a state, and how willing we are to get out ahead of what I think is primarily a federal debate, national debate about how we pay for and deliver healthcare in the state of California. So California does not have complete control over its own destiny on this. We have already been out in front. We have made some choices to do state-only financing for certain populations here, but there's a limit to our capacity to be able to finance the entirety of it. We don't have the same financing power, certainly not the same budgetary power as the federal government does. And you have to remember that the numbers are massive here in the state of California. Right now, 1 out of every 3 Californians is in Medi-Cal. 1 out of every 2 new births in the state of California is Medi-Cal. So imagine we took all of that financial burden on ourselves, not having half of it financed by the federal government, but we try to finance it on our own without any significant coverage there. The state is looking at some methodologies here, and this is things that are potentially within its purview to go alone on. There was a debate in the last legislative session, it will come back, about creating an Office of Healthcare Affordability to try and pull some of those costs down. That debate will be back in full force. What CMA will be looking for in that debate is whether there are real savings achieved, and are those savings returned to the policyholders themselves or to the purchasers, or is it being swept away somewhere else, maybe increasing margins for health plans and others. Another thing we'll be concerned about, and we expressed this concern during the debate over AB 1130, is if it places too great a burden on small community providers themselves. Again, that hard hit provider portion of the provider community, we fear it'll drive greater consolidation as physicians look to sell their practices. And right now, for those practices that are under strain, 3/4 of them are already looking to potentially sell their practice to a larger entity. Those larger entities may not be as interested in providing care in those underserved communities or to hard to reach patient populations. But that is something the state can do without action from the feds, and something that it can get out in front of and help lead on as we think about some of these pieces. And I apologize. I'm going to try it with. I see things popping up in the chat, so I'll try and keep an eye on those as we talk through
Dustin,
this. Yep.
we can actually moderate those, so you don't have to worry about the chat.
Okay, fantastic. Thank you. Another item I was asked to touch on was, how does the American Rescue Plan support expansion? A lot of this since flowing through Covered California in 2021, we now have a very affordable system in Covered California. More than half of Covered California enrollees pay $10 or less per month. 3 out of every 4 paid less than $100 per month for comprehensive care. As I said, that Peter Lee and the board over there at Covered California has done an excellent job of building out networks, making them robust, making them very accessible for patients. We'll be monitoring whether in the Build Back Better Act, those subsidies are expanded beyond 2022, but we certainly hope that they are. But we are fortunate to have that, again, that overlay on top of Medi-Cal and California, having Covered California, and having that. We were the most aggressive in getting our version of an exchange stood up. And I think they've done an excellent job filling in for that middle gap. So if you're lower income, you're getting covered through Medi-Cal. If you're fortunate enough to be in a job with private insurance, you're covered there. There's a whole lot of people that are in jobs that don't have private coverage, and Covered California provides a solution for that. As we also think about expansion, we have to think and consider about physician reimbursement and provider reimbursement. As Dr. Flores mentioned, I served as a co-chair of Proposition 56. That was a tobacco tax, $2 per pack tobacco tax that we passed just 4 years ago. And that was the first significant Medi-Cal rate increase that physicians have enjoyed in the better part of 20 years, which is a really stunning thing to think about. Again, as aggressive as we've been about expanding Medi-Cal, we have not kept up with making sure that we have robust provider networks in the state. Proposition 56 made the first significant investment in that. It's only been fully implemented for 2 years, so we haven't seen the net effect of that investment. We haven't been able to do a full analysis of what it means. But our argument to voters at the time, and it was rewarded, was we can't just invest in expansion. You got to invest in access as well. And that means investing in our provider community. Dr. Flores also mentioned, and just something not to lose sight of, that coming out of Proposition 56, we also have now significant investments in physician loan repayment programs that focuses specifically on the physician population that's taking care of Medi-Cal patients. Get $300,000 wiped out in their debt. Again, first significant one, and what we're seeing is more demand than we're able to fund. We're hoping that the governor will put more money into that program and expand it in perpetuity. One good thing that came out of last year's budget, and thinking about Proposition 56, Governor Brown and initially Governor Newsom had looked to actually cut Prop 56 rates and try and pull some of that money back to offset state deficits. We were able to beat those back on a temporary basis last year, given the size of the surplus. The governor wiped out those pending future cuts in Proposition 56 and fully funded them as intended by the voters. I know there's a drive here to try and get rates up to 100% Medicare in Medi-Cal. It's got an awful long way to go to get that. Depending on your specialty, there's differential there, but many physicians under the Medi-Cal program are paid at 50% of Medicare and have a long ways to go. We were able to get some of those rates up again through Prop 56 and close some of that gap, but we need a lot more than we were able to raise in Prop 56 to be able to get that part done. Before we open it up to dialogue and conversation, Dr. Flores, I want to give everybody a sense of some of the politics that will be playing out in the coming year. The governor is coming out of a successful campaign against the recall effort that he was facing. But right after this, he's up this coming November for re-election. We don't know who his opponents will be there, but we're kind of now in the second year of a very long campaign about the governor's performance and about what the future of California will be. I believe that he'll be successful in his re-election as he was successful in beating back the recall. It's hard to see a pathway for anybody to challenge him so soon after what was effectively, in my view, a re-election campaign. That does give the governor quite a long runway. Think of it as almost as a 5-year second term to drive the direction about healthcare for California forward. I said he was a healthcare governor, campaigned as one, and I believe he'll remain committed to that. But what path he takes is yet to be seen in these next 5 years. Does he go back to some of the early campaign rhetoric around single payer and try and drive that through? Does he continue to double down on what he has done in office to date, which is to build on the successes of the Affordable Care Act and focus on continued expansion under Medi-Cal, or again, pivoting to a different direction? I think that's what we'll watch over the next year as he engages both in the policy-making part of his job and the political part of getting reelected. On the state legislative side, the legislature is dominated by Democrats here in California. In both houses, they enjoy super majorities and can pass pretty much anything that they choose to without the need for Republican votes. But within the Democratic Party itself, you have major splits between those that will support a single payer program, those that will support continued expansion based on the Affordable Care Act. We're watching that same dynamic play out in Washington, D.C., but in Washington, D.C., the majorities are far narrower than they are here. We don't have a filibuster rule. We don't have other things that the federal government or the federal legislators have to contend with as they contemplate expansion of coverage here in the state. And I'll reiterate for the physicians on the call, if you want to get engaged in the policymaking part of CMA and about how CMA is going to engage in this, that committee is meeting now and recommending to the board what our future position will be on this issue as we respond to what the commission does that the governor's appointed, and as we engage in the legislative debate and fight that's to come. I always say where CMA goes, that's usually where the healthcare debate goes. I've watched it time and time again during my tenure here. When we've changed our position, it changes the debate in the state legislature. It changes the dynamics when physicians endorse a particular position or a particular strategy. So I'd encourage all of you, again, get engaged in the policymaking process. It's going to play out here in the next couple of months, and then we'll take it from there after the Board of Trustees meeting for this coming legislative session. Hector, maybe I'll stop there and try and catch up on all these chats and questions.
Well, thank you so much, first of all, for that great overview. And Dr. Deen, if you're able to connect, please feel free to chime in. So.
Thank you. Yeah, Dustin, that was excellent. Thank you for all that information. I think this is the whole idea is to educate us, to get us all thinking about this and having our voices heard. As I always say, we either have a seat at the table or we're on the menu, and traditionally we tend to end up on the menu. So this is good. I just want to take a minute here to thank all of you for being here. I want to especially thank Dr. Jeffrey Lee, who's on the call, current president of LACMA, for his support and hard work on this. So thank you for that. I'd like to thank Gustavo and Lisa, who are both on the call as well. Incredible hard work putting this together and supporting us. Thank you, guys. Jerry Abraham is current treasurer for the LACMA board with me. I don't know if he's on the call, but I wanted to thank him also. And of course, Dr. Flores. Dr. Flores and I have been working together on this. So Dr. Flores, thank you for that. So let's kind of hear from everybody. I'd like to kind of field some questions for Dustin. Again, what we're trying to do here is educational, it's thought-provoking. There are pros and cons to everything, and we want to make sure that we are thoughtful and deliberate about our conversation and our actions collectively as LACMA and CMA. So please feel free to put your questions in the chat, and Hector, I'll let you moderate.
Yeah, there's some really good questions already, and thank you to those who submitted ahead of time. One, Dustin, is around the patient, the consumer, and those that are the beneficiaries. Where is their voice in this process?
Well, I think it's pretty well heard. If patients are the ones ultimately expressing their voices through their vote. You can have constituencies within healthcare, but we're all patients at the end of the day, and we all have the opportunity to vote for who we want to represent us, both the state legislature and federally. In addition to that, there's a lot of patient groups that are heavily engaged in this conversation as well. And then I think physicians, ultimately, what's good for patients is good for physicians, and I think there's a great alignment there as well. So I think their voices are well heard, but like with many things, patients have different opinions about what system may be the best for them. Maybe that's situational, maybe it's political, but that debate will happen here. But at the end of the day, we're all patients, so I think we're all members of that organization.
Well, and you're right, but that may be the voice of certain people. We know that there's many who are disenfranchised and not politically powerful because they don't have funding to have big fundraisers and have a voice at the table. And we see that even with physicians. There was a question in the chat, but also recently we had a meeting of our Medi-Cal Provider Committee and the LA County Medical Association. And a lot of physicians have still not heard of Prop 56, augmented payments. Some of them get pleasantly surprised because they get a check all of a sudden, but they don't know what it's for. And then others are aware that the program exists, but they don't know where to get paid. What would you recommend to them?
Well, we have an entire department here at CMA that helps physicians through that. So they're welcome to contact Jody Black at CMA. She runs the department here, Center for Economic Services, that helps physicians get paid. We have a direct interface with the California state government, Department of Healthcare Services, that manages Prop 56 and the broader Medi-Cal program. And we can help with that, or we can help interface with the private payers as well, the Medi-Cal managed care companies that have most of the lives in the state. And so we work with every single payer. It works out well. Prop 56 can be hard to understand about how and who is getting paid. There's supplemental payments that lay on top of the base payments for Medi-Cal. So we can help walk through that either on an educational basis or on an advocacy basis, making sure that individual physicians that are eligible or medical groups that are eligible are getting properly compensated under Prop 56 for the codes that they should be. There is some explanation that comes along with that, again, because of how Prop 56 was implemented in the Medi-Cal program.
And, is there a number or can they go to
Yeah,
our website if they're not a member?
Yeah, I will. Well, I was going to type in the chat here. Maybe that's the easiest. I'll put in Jody's email. That is, I'll put her full name.
In the pre-submitted questions, one question was around moving upstream. The governor wants to start looking more at prevention and getting away from purely the medical model. Value-based gets thrown around, right? Where's the CMA on that? Because the prevailing thought is that physicians really need to define what value is, not the health plans, not the purchasers. Where does the CMA stand on that?
We are supporters of value-based medicine, and we'll be supportive of the governor's efforts there. And there'll be a big debate over the implementation of CalAIM and some other aggressive measures that the governor is promoting right now. But thinking about a broad view of value-based medicine, we do want to be able to make sure that physicians are aligned with patient outcomes, good patient outcomes. And that they're able to be properly compensated for those services, and moving out of a turn and burn model, getting out of that fee-for-service model, and being able to invest time and resources in those patients that need it the most. Something that always pops into my head: my father has Parkinson's. We go to the same physician. He needs vastly different services from our shared physician than I do at my age, and the ability for our physician to be able to spend the time with him to make sure that he's doing his exercises, that he's doing all the things that he needs to do to remain healthy and not have his disease progress isn't done in a 15-minute visit. Almost everything I need can be handled in a 15-minute visit, if it even takes that long. But for my father, that's vastly different. And so we want physicians to be able to take care of the more complex patients, be able to be fairly compensated for that. And for those patients that may have not just an advanced disease like Parkinson's, but just frankly need more time. Maybe it's a linguistic challenge. Maybe it's not having familiarity with the medical system. All those different things, we want physicians, we want the nurses in that practice, the NPs, the PAs, to be able to spend time and really invest in that. We also want to be able to give physicians the tools that they need to be able to practice in that type of environment. Those types of tools should not just be available to those that are part of well-funded systems. That should be available to every single physician practice, every single clinic in the state of California, irrespective of their payer mix. And if we're going to be able to do that, we're going to need to invest a whole lot more in those practices. And there's been a bit of that, but we need a whole lot more of that so that physicians can practice the type of medicine they went to school to be able to do. Again, I want to see that in the Medi-Cal program as prevalent as it ought to be in the commercial side as well. Something that thinking about broader than some state action here. One of the things we got to deal with too is that for an awful lot of physicians, even in relatively large practices, the group itself might be capitated, but underneath that, the physicians are still being paid on an RVU basis, effectively fee for service, and are yet not in true value-based payment arrangements. So we want to see that in small practices. We want to see that in large practices. And again, irrespective of payer mix, the ability to practice medicine that's aligned with the patient's need and patient outcomes, not just volume, not just churn and burn. That drives burnout for physicians. leads to poorer outcomes for patients. If we fundamentally change that, reimagine how it's done, I think you're going to have more satisfied workforce, but you're going to have a lot better outcome with patients to a healthier state and a happier population. So CMA is all in on that, and we want to see it implemented writ large. And we have a lot to learn from some groups that have done it extraordinarily well, and take a lot of those lessons that have been learned and apply them across the board. We are in fact partnering with a couple companies in order to accomplish that for physicians. We have a partnership with Valuebased, which is a national company, and a company here homegrown in the state of California, Alteas, to try and bring those tools and those services to physicians all across the state.
Thanks. Another component here is that, sometimes people talk about single payer, but there's different types of single payers. And what do you see is happening, or what do you think the commission might recommend? And how does that play out with sustainable single payer models? And is there a role for insurance companies, and is there a role for Medicare Advantage, for example?
Yeah, and I think when we talk about single payer versus a single financier, those are two different things. Single payer can be everything swept into one, elimination of commercial plans, everything running through the government itself. Single financing system, still have a multi-payer system, still have health plans, still have Medicare Advantage, still have some of those other elements. I think Dr. Lee was getting to this in his question there in the chat. I think that's where the commission is heading and where it's likely to go. We'll see what their report is when it comes out in January, but I think they're going down that pathway rather than a more British model. I think they're going to lean more towards a German type model where you do have multi-payers as we traditionally think of them, health plans, but a more unified financing model a la Germany.
And there's a question in the chat that looks at the wealth that California has. If we were a nation, we would be the 5th largest economy. And we keep throwing money at the problem, but we don't seem to get our arms around a comprehensive strategy. And so the question is we need bold leadership, bold ideas, and bold steps to universal coverage, addressing the workforce issues, et cetera. And I guess inherent in that question is, if you were czar and you could say, this is what we're going to do, what direction would California take?
Well, I don't want to get out ahead of the debate that the Board of Trustees is going to have, so I'm gonna punt on that one, Dr. Flores. I work for the California Medical Association. I don't decide on my own where it's heading, and that's a debate that the physicians need to have. And I have no doubt it'll be a robust one. But I will wait to see that the direction as adopted by the Board of Trustees, informed by our House delegates, more recent debate, and let the committee and the board do their good work.
Makes sense. Dr. William Arroyo is on the one of the committees that you mentioned, and he would like to make a comment. Dr. Arroyo?
Yeah, hello, Dustin. Thanks for making the time to meet with us. And I was wondering how long it was going to take you to mention the Dodgers. I was going to mention it for you, knowing you're a great fan, but you beat me to it. Jesus.
So on cue.
Hey. Anyway, that being said, I've had the privilege of being a member of this committee that is developing opinion for the rest of the association to consider, and then of course the Board of Trustees to make some final determination on. I've also managed to catch every one of the commission meetings, and so I have been able to listen to all the information that has been shared with the commission and their comments, frankly. And I personally have learned about the various different models around the world, particularly those in industrialized nations. We also had as one of our guests, former governor of Vermont, where some of you may recall, he and a team did come up with a plan for what was a unified financing healthcare delivery system. However, as he described it, while it worked on paper, the political winds, by the time there was going to be a vote, had turned around, and it fell on its face and failed. As Dustin has suggested, and this governor suggested, the optimum time for California to make any major progress toward a unified financing healthcare delivery system model is to have all of Congress be Democratic, or have them support this in California, because without that, it's not going to happen in who knows how many years. Because as Dustin is suggesting, not only does Medicaid and Medicare have to change, but so does ERISA. And some of you may be familiar with that federal act that governs approximately 47% of the insured people's plans here in California. That's a big chunk. Without changing those three federal laws, there's no way, despite the $37 billion surplus we have in California, that we could cover those costs, in my opinion. The other thing I should note is that it's no secret to everyone on this call that the healthcare costs of our country is at a level that is not sustainable. The healthcare costs in the U.S. accounts for 17% of gross domestic product, whereas in these other industrialized countries, the healthcare costs account for somewhere between 5 and 7% of their GDP. So we're more than twice theirs. And while the healthcare delivery system works for some people in California, I think the pandemic uncovered the fact that it doesn't work for a lot of people. And so something needs to change. I just don't see us moving toward a unified financing model, given the politics that need to be in place for it to happen, not in the near future. You know, whether or not there could be a 20-year plan, who knows? But I just wanted to share, some of these thoughts, some of these things that I've learned over the course of the past really 8 months, and we're working in finalizing our draft in the next week or two, at which point I believe it'll be circulated, and then it goes to the Board of Trustees at the end of January. Dustin, I don't know if
that's correct.
Timeline that you have seen, but it's been quite an eye opener for me on many different levels.
Thank you, Dr. Arroyo. That's a great point. Kind of following up on that, especially with comparative health systems, Dr. Stephanie Booth sent a resource to me earlier. And Stephanie, if you don't mind, could you put it in the chat? It's from the Commonwealth Fund. And they looked at exactly what Dr. Arroyo was talking about. European countries spent, for every dollar they spend on healthcare, they spend $2 on social services. And that's what allows them to, have a healthier population and, have early visitation for pregnancies and then postpartum, et cetera. We spend a lot of money on the healthcare side. For every $2 we spend on healthcare, we spend 50 cents on social programs. And if you look at it from a per capita perspective or annual, total budget perspective, we're spending a lot of money on, the horses leaving the barn and not doing anything to prevent the horses from leaving the barn. What do you see in CalAIM and some of the other initiatives that the governor is considering that might help get to that point where we're making better investments in social services and prevention?
Well, I think there's a greater attention is being paid to both sides, as using your analogy of trying to address issues before the horses left the barn, and investing more in some of what causes poor health outcomes or poor health to begin with. And I think through CalAIM, I think the procurement process that managed care plans in the Medi-Cal system are going through, there will be an emphasis on that. How well are payers aligning around that new focus? How well is the state itself trying to align around that focus? I think that's where physicians, again, getting into more value-based payment arrangements can be well positioned to do well under CalAIM and under some of the realigned proposal that the governor is going to be either continuing to implement or pursuing in the upcoming budget cycle. All of them have a common theme, and I saw a lot of justice, diversity, inclusion issues being brought up in the comment box as well. And that's got to be a focus of this. It's got to be a priority. Again, the disparities within our state are stunning and staggering and completely unacceptable when we look at where healthcare resources are going, when we look at healthcare outcomes. And I think that is the intent, that's the hope of CalAIM and some of the reforms that are being contemplated in the Medi-Cal system itself. It is a huge payer, but it's not just Medi-Cal. It's other payers that are aligning around some of these changes as well. CalPERS is the largest purchaser of healthcare outside of the federal government. You have Covered California, and entities like that are pursuing these goals and these efforts as well. So I think there's going to be more accountability for private payers to invest resources in some of the social determinants of health. And I think there'll be a greater push for physicians to be aligned around those programs as well. And we certainly stand ready to help physicians and others through that shifting environment.
Thanks. And many observers and consumers talk about it's the costs, that need to be controlled. And the first item that comes up is the pharmaceutical costs, right? And we have starting January, the Medi-Cal RX, where the state will try to use its buying power to negotiate better prices for consumers. Do you see that getting traction and maybe engaging other purchasers to do the same thing?
Yeah, it's tough here at the state level with some of the federal restrictions that are there. We see more action there at the federal side. I know there's some congressional movement happening potentially there, but we'll see how successful the state can be. Also see maybe some more private payers and purchasers of healthcare, those that contract with health plans, putting greater pressure on some of these changes as well, greater transparency in the PBM market, in addition to some push on the manufacturers themselves. But the state has tried to go down this road a few times and has not been terribly successful. And I'm very worried about the rollout of Medi-Cal RX as it stands at the moment.
Thanks. There's a question in the chat as well, looking at the corporatization of medicine, which was a big topic at the House of Delegates, especially with private equity coming in and basically, beating up on the competition and trying to make commodities out of doctors' practices. How do you see that evolving here in California, and where's the CMA sort of looking to protect patients and their doctors?
Well, it's exponential acquisition at this point. We saw rapid acquisition of physician practices happening pre-COVID. COVID, because of the financial stress that it's put on physician practices, has just lit an absolute fire on these acquisitions. It used to be a few specialties that were being targeted for acquisition by private equity. That's expanding out now. It's not just single specialties, it's family practice as well. And it used to be the dominion of hospitals. Now it's physician practices are being acquired by health plans, are being acquired by hospitals, being acquired by private equity. And that new private equity entrance again into not just single specialties like oncology and dermatology, but now focusing on primary care as well, I think should give everybody pause, and something that we need to look at very, very closely about the impact on medicine, on the delivery of medicine. Where's the ROI going to come from in order to put returns on those acquisitions? It's something that we need to look at very, very closely. And the House delegates, I thought, had a very vigorous debate on this, has made a number of policy recommendations on it. We'll be pursuing some of those in this legislative cycle, but it's also something that we got to put out there in the marketplace and provide alternatives for physicians, so they're not their only choice isn't just to sell their practice. How do we give financial resources and tools for physicians to be able to make the choice about how they practice? How you practice shouldn't be dictated by a financial necessity. It should be about the way you want to practice and making sure that you can provide the care to the patients that you want to be able to see, not something you have to do because you have no other choice in the matter. And unfortunately, with the pandemic, we're just seeing more and more of that. Physicians can't pay bills, they can't stay afloat, and their only choice is to sell. And too often, not always, I don't want to put everybody in the same group. I want to put every acquirer in the same bucket. But too often, we get calls here at CMA post-acquisition of physicians regretting that decision, feeling like they're being worked even harder and for less pay than they were making before, having to practice a very different type of medicine than they were originally practicing in their practice, feeling more burnout and poorer outcomes for their patients. So again, not all acquirers go into that same bucket, but we also need to help physicians make good choices about who they partner with if they're going to partner. The first step in this process is making sure that there's choice in the marketplace about how and for whom you practice. So again, you can anchor it around what's best for your patients, not what you have to do as a financial necessity. A couple comments about costs going up. We do see that. Physicians Advocacy Institute put out I think a very good study, an excellent study about the rapid consolidation in the healthcare system and what that has meant for overall costs in the care. One of the things that we're looking to do in our physician service organization, it's a subsidiary of CMA, is trying to bring the upsides of integration, clinical integration, without the downsides of economic consolidation. The two things don't need to go together. We think we can bring clinical integration into the marketplace for physicians without there being necessarily corporate integration of those entities.
Great, thank you very much. We're coming to the end of the hour, and so I'd like to do is have one more time for one more comment. And I see Dr. Steve Tarzinski's put in some really interesting comments. Steve, could I ask you to talk a little bit about, he's the president of the California Physicians Alliance. They have a roadmap for healthcare reform in California. It's one of the big fears that we have. Victor Fuchs from Stanford says, that if things continue the way they are, as Dr. Arroyo actually was describing them, we're going to hit a point where single payer is inevitable, but there's no magic switch to turn it on, and it'll make single payer look bad, and it'll hurt people and doctors at the same time. Dr. Tarzinski, could you comment on the CAPA plan, and then we'll wrap up.
Yeah, thanks, Hector. I also put something in the chat box. And thank you, Dustin, for an excellent presentation. Very good. I'm Steve Tarzinski. I'm president of the California Physicians Alliance. I think there's sometimes there's a false dichotomy pitting, supporting single payer and building on the Affordable Care Act. I think that circle can be squared. And I think what we try to do in CAPA is develop a roadmap that tries to do that. And, we looked at how no one's actually really figured out how actually would we get from what we have now to a system of unified public financing. And I think, we looked at it in terms of it has to be done in phases. There's going to have to be legislative changes and non-legislative or system changes. We have to look at we looked at 5 key strategic policy areas or domains. Maybe there's more, but we could think of 5. They were cost and price, universality, insurance company behavior, appropriate insurance company behavior, improving public systems, because they have to be done before we could even get public confidence in moving to a public system, unified public financing, and also future workforce development. And so those are the 5 areas we looked at. And I think it's a question really, everybody here knows it's a question of risk pool size. We know that the larger the risk pool, the lower the cost. And the largest risk pool is the nation, or certainly with California, a very large state like ours, with the world's 5th largest economy. So I think some way to gradually look at how we could increase risk pool sizes over time as well is another way to look at it. So that's what we tried to do with our roadmap, and we submitted it to the commission, the Healthy California for All Commission, and have been discussing it with key legislators as well. So I would invite people to take a closer look at it, and we'd love to get your feedback on it, and certainly are absolutely willing to share it with the CMA and get their feedback. So thanks, Hector.
Thank you, Steve. Please then for the audience, join me on giving a big applause to Dustin for a great presentation, very thought-provoking at the same time. And Dr. Deen, I'll hand it over to you to wrap up.
Thank you, Dustin. Thank you, everybody, for joining the call. I think this was a great discussion, and I think a fantastic way for us to start this series on discussing various options for healthcare reform. And along the way, one area that I'm interested in is, all of us are in different practice settings. Some are employed, some are private practice, some are in groups, and we're at different stages of our careers. The older doctors, more experienced senior doctors amongst us have experienced things in healthcare and payers and insurers that others have not. And so what I'm hoping to gain through this, among other things, is to share our experiences, to learn from each other in our various practice settings. And a lot of times that opens our eyes to areas of pain in each other's practices that we otherwise would be oblivious to, frankly. So thank you for that. I think we touched on some of that, and we could probably have a 10-hour-long session just on that alone if we wanted to. So, but anyway, I know we didn't get to everything. I know that we got to some of the key points. We'll continue discussing more in upcoming months. So thank you all for joining us. And happy holidays to everybody. Wish you and your families the best, and happiest blessed 2022 also if I don't see you.
Thank you again. Good night, everyone.
Thank
That
you.
concludes our program. Thank you.
Thank you.